All right, everybody, we're going to get started with our next presentation. The title of the presentation is Can We Do It on Zoom? A multi-sector collaboration to increase children's dental care access. Presenters today are Tanya, Edgar, I can't believe I didn't know that, Public Health Nurse Manager at Olmsted County Public Health, and Virginia Jeltema. Did I have that right? What? Close enough? Okay. She's a public health strategist with Olmsted Public Health. Welcome.
All right, thank you, Nancy. Yeah, as she said, I'm Tanya Edgar. I'm a nurse manager for our school aid services team with Olmsted County, which I'll explain that to everyone because it's a unique team. I have a team of 9 public health nurses that are directly embedded with our schools within Olmsted County.
And yes, thank you, Nancy. My name is Virginia Jeltema. It's close. It's Dutch. It wasn't my name. It was someone else's, and I got it. I still love it. And I am a public health strategist, so I do a lot of data analysis and project management, and I'll be presenting a lot of data today, so hope you're ready. The title of our presentation is the question that we asked at the beginning of our project, can we do it on Zoom? The short answer is yes, but today we'd like to talk about the how. Here are our learning objectives. We're really excited to share our work, and we hope you walk away with something today that can aid you in your work. Some background to start. So here comes the data. We are in the Southeast region, so one of the few regions that was not just presented to you. We are highlighted there in red, Olmsted County. We are a population of around 160,000, primarily in Rochester, but also throughout the county. Here you can see the population of children ages 0 to 20 in our county, how that's grown over the years. Around 37% of children 0 to 20 are on public insurance, Medicaid, or medical assistance. And here you can see a breakdown by different age groups. It's probably a little small, but it's by the different age groups, 0 to 20. So when we started this work, we wanted to make sure we got a good sense of what was happening in our local community and at the state level when it came to both dental problems and dental access, especially for children in our community because we are the Children's Dental Task Force. So here is data from the basic screening survey. It's something done by MDH every 5 years or so. This data is from 2015 because of the pandemic. But essentially they went in and they looked within children's mouths to see how many children had cavities. And they found that cavities were very prevalent. 50% of the children that they looked at had cavities. And furthermore, they did find disparities among different populations. So the 2 graphs here illustrate that non-white, non-Hispanic, and Hispanic students were more likely to have cavities than their white counterparts. And also those coming from lower income families were more likely to have cavities as well. We wanted to look specifically within our own county. That was for statewide. So we looked at the Minnesota Student Survey, which is a survey that goes out every 3 years to participating school districts, children in, or I should say students in 5th, 8th, 9th, and 11th grade answer these questions. And one of the questions that they ask is, in the last year, did you have any dental problems? So here you can see it's a little small again. The last 2 cycles of data, 2019 and 2022, we are in the red, and you can see Minnesota overall in the yellow. 32% of students said that they had experienced some kind of dental problem. And that ranged, as you can see in the bullet points, from cavities to toothaches and pain to not being able to eat certain food because of a dental issue. We also wanted to take a look at dental care, as I mentioned. So we also looked, the Minnesota Student Survey does ask about, have you seen a dentist in the last year? And in 2022, 82% of students said that they had, which is higher than Minnesota, as you can see from the graph. We also wanted to understand if there were any disparities within certain populations, because this is for all people taking that survey. So we did find some statistically significant differences. So for example, that first bullet point you see there, 71% of students with fair or poor health saw a dentist in the last year. That was significantly lower than students with good or excellent health. And you can see some other comparisons as well, some of which we saw in the basic screening survey as well. Latina students were less likely to have seen a dentist, non-white students, non-cisgender, non-heterosexual students, as well as students with a disability or long-term condition. And interestingly, when compared to their female peers, male students were also less likely to have seen the dentist in the last year. None of these sources looked at insurance type, and that was something that we really wanted to look at because we have a lot of dental professionals in our group, and they know from their experience that insurance matters when it comes to care access. So this is data from the American Dental Association, and you can see the clear gap between those who are publicly insured and those who have private insurance. In terms of dental care access, those who have seen a dentist in the last year. So 75% of those with private insurance had seen a dentist compared to 39%. That's statewide data. When we took a look at our county specifically, we saw that that held, and it's also been over time a lot lower for our publicly insured children. This comes to us from billing data. It's on the Minnesota Department of Human Services Legislative Dental Dashboard. When we looked at data from our programs, child and teen checkups, again, we see that it's a low number receiving care within the last year. We also wanted to look at not only dental services, but oral health services as well, because we know that doctors provide care like fluoride varnish and appointments. Clearly not very many children are receiving those, and around 9% had that according to the billing data. So we know that there's issues with access, especially when it comes to insurance type, and we know that the dental problems are very prevalent in our county. And I'll pass it over to Tanya to talk more about this project that we started to address this.
So we had a previous dental task force. Yes, we had a previous dental task force. Actually, that was started back in 2014 by a doctor at Mayo, Dr. Valeria Cristiani, and Dr. Marty Alleman. She was my predecessor for our school-age services team. The group's mission back at that time was to promote children's oral health by fostering collaboration between dental and non-dental providers in our community. They achieved several things in the 5 years that that group was together. Two of those significant accomplishments were collaboration with other county programs to promote dental health and establishing a dental health home for patients. And they also worked with Mayo Clinic to begin providing fluoride varnish treatments at well child appointments, which they still do to that today. Back in fall of 2019, the group disbanded. They kind of figured that they had done as much as they could at that time with the task force. And of course, at that time, we know what came next after fall of 2019. So fast forward now to 2024. Things were not any better, obviously. We knew that we needed to do something, and from my team's perspective, we were noticing, kids at school were missing lots of school, as we've heard from other presentations. The kids were missing school due to dental issues. Many of the referrals that my staff were getting were assisting with kids to get to dental appointments. Many times the waits were very, very long, and damage had already been done. Lots of times we were seeing kids that were even to have permanent teeth removed. So we were trying to figure out we needed to get the group restarted. So my first step was to reach out to internal public health staff to try and find out, to get voices from our other partners. So we had people from my team. I reached out to our people in WIC, our family home visiting team, and just whoever I could from public health to get to join to make sure we had the right voices there. I also needed a connection back to Mayo Clinic since the doctor had retired. So she helped me find a pediatrician that was able to join, who found a peer. So we ended up with 2 pediatricians on our team now. And then I just started cold emailing people from the old group. So our original distribution list, in the beginning when I started, had 13 people on it, 9 external people and 4 people from public health. From there, people just started recommending other people to call. And you can see from the slide, we've got good representation from our area. I also reached out to our health plans, knowing that having access to providers was an issue. So I was hoping that they could help us maybe get more providers on the list. Someone even recommended reaching out to the Minnesota Oral Health Coalition. So I emailed Nancy, and that's why we're here today. We've added a social worker from the county who works with our Children's Disability Services team. We have dental hygienists. We actually have an instructor from the Rochester campus at the Winona State University. We have dental therapists. We have an operations manager. We've since added our public health child and teen checkup coordinator. We have people reaching out to me now that have heard about the task force. So, and I'm happy to say that our current distribution list now has 33 members on it. So Not everyone comes. We average about maybe 15 people that join our meetings. But all I can say is if you build it, they will come. Is this me? So why on Zoom? Our meetings back in 2019, they met monthly in person after hours at 5:30. So when I started calling people, people didn't want to do that again. That was the first thing they said. Do we have to meet in person? Is it going to be after hours? And honestly, when they started asking, I should go back up and say, one of those first meetings that we had in 2019, when I was there was a meeting that was supposed to be held on Zoom, and they asked me where the equipment was, and I even said, I didn't even know what Zoom was. So fast forward now, I do know what all of this is. We have the proper technology thanks to the pandemic, so we are able to do everything remotely. So I was able to tell them, yes, our meetings they'll be remote. You don't have to, come after work. You don't have to do any of those things. So it's much improved. We meet every 6 weeks. Actually, our next meeting is tomorrow morning, which saves a lot of time for people. So we record everything. We have a shared team site that we put all of our meeting notes. We record things, so if people miss it, they're able to listen afterwards. There's a repository for all of our data. So even though we're totally remote and everyone's at their own site, we're able to collaborate and they're able to see everything that we work on. So it works much better than what the previous task force did.
So we had decided to do everything online. And when we made that decision, we knew that it was going to be a new way of working on this specific type of project work. And so we wanted to have a very clear roadmap for the project, so that way we could all have a shared understanding and be able to work well together in this virtual environment. So these are the 3 key elements that helped us create that roadmap. We use results-based accountability, or RBA. That's something that we use throughout our health department. It's in the name. We focus a lot on results, on the data, on the evidence that we can use to see that something works, and as we test something out to see if it works. We also use quality improvement, which is a very similar idea, right? You watch a trend, you see if something's going wrong, and then you see what kind of improvements you can make, and if they work, and then you continue that cycle. The other element I wanted to call attention to up here is called technology of participation. It's a way to facilitate work. There's a lot of great exercises. In this picture, you can see it's often done in person with a sticky wall, if you've ever been a part of those types of meetings. So we found a way to translate that to the virtual environment, so that way we could do some consensus work and be able to work together with all these different ideas. So here is our roadmap. Our project is not done. We're around step 5 right now, but we're excited to show you some of the different pieces that have come out of these steps. Obviously, step 1, I've already showed you a lot of the data that we dug into at the start of this project. From there, we created a problem statement to take a piece out of this problem, since we know it's a big problem and there's a lot of different elements to it. From there, we examined root causes, and then we moved to brainstorm improvement ideas that would address underlying causes rather than surface level ones. And so right now, we're working on our interventions that we've chosen. Here's some more specifics on our toolbox. So we use Microsoft Teams, not technically Zoom. Microsoft Teams is what we use, as well as some technologies like Mentimeter. Today we'll actually have an opportunity for you to test out Canva, but we used Whiteboard from Microsoft for most of our work. You can also see some of the exercises that we get from quality improvement and other places when it comes to root cause analysis, 5 whys, technology participation, that consensus workshop. So as we're going through, I just wanted to show you how we did those steps within our roadmap. So when we created our problem statement, we used Mentimeter to be able to ask questions and see results in real time together. And so we asked, who is this problem impacting? What is actually happening? When and where is it occurring? And why is it important for us to solve? So everyone in the meeting gave their responses, and we were able to put all of those onto a Word document, which is on the right there. You can see specifically for one question, that why question, why is it important for us to solve? So we took everyone's responses from the meeting, stuck it into a Word document, and did theming. So for example, you can see the yellow highlights there. It speaks to themes from different responses on it being a long-term condition. The pink talks about how oral health is connected to our overall health. So we were able to theme down and then come up with concise consensus statements for each of those questions that we then composed into a problem statement, brought back to the full team, they reviewed, edited, and we finalized. So that's how we got this beautiful problem statement that you can see here. I won't read it to you word for word, but you can clearly see the data point that we anchored around. We wanted to specifically address those who are on Medicaid, our children who are on Medicaid insurance, as well as the uninsured for their access. And you can also see the importance. There's a lot of very passionate people involved in this task force. We're very lucky to have all of them. Some of them are in the room or online, so thank you so much for your time. But very passionate and really understand the importance of this work. So we wanted to highlight that in our problem statement. We did root cause analysis using Microsoft Teams. There's a template there if ever you want to try it. You can see a lot of words up here, a little too small to read, but the general idea, you see our big problem in the head of the fish, and then the general themes as to why that's occurring with more details on the bones or the fins. So we did a lot of work to talk through why is this happening and go through all the details. And then we asked the group, what are we best able to address? Because there's a lot happening here, right? But our task force can't necessarily focus on everything. So what are we best able to address? And that's where you see the two circled fins and what we wanted to bring into our brainstorming phase to start thinking about solutions. And then we brainstormed. So this is where we blended Microsoft Whiteboard along with technology of participation. And with the technology of participation consensus workshop, it has you brainstorm at 3 different levels. You do the individual, so everyone in the room jots down 10 or so ideas that they have for how we can address a problem. Then we move to small teams. Everyone reviews everyone's ideas, and they kind of filter through and determine their top 10 that we then bring to the full group. And then the full group goes through and we start organizing. We see where there's overlap, where we can put things together. So this is the template that we started with. And I will note, we're very lucky within the government space to have Microsoft Teams and access to all these tools. Our IT is also very passionate about security, so it is locked down. Unfortunately, we found that out doing this project. It might be different for other accounts, but we learned that the only people who can actually type on a whiteboard or move things on a whiteboard are people within our organization. We found a way to do that. We used facilitators within our small groups to do that work. But I did want to highlight we overcame some challenges as we went through. But we started from here and we got to this. Which I realize, again, may be hard to read from far away, but you can see clear columns of ideas that are themed out with the different colors. We had a column about increasing mobile access options. We had a column talking about education for the community. The gray column had a bunch of ideas talking about innovative access strategies. Purple was all about talking to our dental and health providers with practical information on how they could better connect patients to care. And then the green focused a lot on our workforce. How can we support our current and future workforce? And there are a lot of ideas underneath of those umbrellas. So we, again, similar to that root cause analysis sheet, we couldn't address everything on there. So we needed a way to prioritize what we were going to start with. And this is a screenshot from Mentimeter. Again, we were able to use that tool to do this work here of prioritization. We asked 2 questions. How much effort is this idea going to take and how much impact will it have? And that was our jumping off point to start discussing what we wanted to focus on at the start of our project for each of these strategies, since there was so much we could pursue. So again, each person would respond with a number, 1 to 5, for each of those dimensions. And then Mentimeter automatically filled this visual with those little dots so we could see it happening in real time. So from there, we got to our 3 strategies that we are starting off with now, and I will pass it over to Tanya again.
For somebody who likes to move fast, that really took us a long time to get to this part. So yeah, we have our 3 strategies that we're working on now. Exploding mobile clinic access, which we currently have the UCare dental bus comes to Olmsted County 2 or 3 times a year, and we do have one local provider that comes to our schools. So we've been in process of trying to interview some others to be able to expand that. We do have a couple metro providers that are interested in coming to Olmsted County too, so that's pretty exciting. We're also working with our local dental providers. So we've been reaching out to our local MA providers to try and further understand what their barriers are to accepting more patients and trying to see what resources that they would need to expand services. And then also our third strategy is trying to integrate primary care and dental care. So Mayo Clinic is currently in the beginning phase of a test pilot to start using silver diamine fluoride in primary care. We're also hoping to increase the lines of communication between medical providers and dental providers to ease the process of referrals and trying to just get people from the medical appointments into dental appointments. So super exciting for all three of those things.
So we wanted to give you the opportunity to test out some of these tools and just reflect if there's anything you could use from what we used. And so we found, as I mentioned, Microsoft Whiteboard locks down, and you can only use that truly if you're within the organization. But if you scan this QR code on your screen, or if you're watching later, you should be able to click on the link there. You should be able to access a whiteboard. And if you have Canva, I realize a lot of nonprofits and other organizations use Canva for the wonderful visuals you can create. You can also use this, which is a wonderful tool for being able to collaborate in real time. So if you scan it, it will come up with a little menu, I think with a text editing. You'll need to hit X, and then you'll see a bigger menu at the bottom that says things, elements, tools, those labels. If you click on tools, that's where you'll be able to grab a marker or an eraser, and you can try drawing something in that big circle on the whiteboard. If you want to check out the note cards, there are note cards there. We have an activity where you can write down the last song that you listened to on a green note card. And then at the bottom, you can practice changing the color of the note card based on what the genre of music was. We had some team members test this out, so you can see one of our teammates loves Taylor Swift. And so there's, I think, 2 Taylor Swift songs listed on there. But you can give that a go on your phone, or if you're able to use a computer, even easier on a computer than it is on a phone. The other tool I brought up a couple of times, again, you can scan if you want to check it out. This one's maybe a little more straightforward to use, but you can test out the Mentimeter tool here with this QR code. And we have just some fun questions about fall, since fall is upon us. But you can see the different options, whether that's free response, doing that impact versus effort diagram, or there's also just a simple voting opportunity too. So we hope you can test that out, and if this benefits your work, so happy to have shared it with you. I think with that, we'll leave time for questions.
I just want to say that I am a part of the group, and I heard you talking about when I was running around with some errands, but you guys have been able to do this so well on Teams. It's really incredible. And I love all the tools because it does feel like I'm part of the process. I'm not just sitting, and I'm not also feeling, sometimes I feel a little scared. I'm like, are they gonna call on me? Is this gonna be real? I never feel that way in your meetings. So I just wanted to share that. I mean, these are great tools that you're sharing with us, so thank you.
Thank you. Yes.
I would appreciate it if you would comment a little bit further on just sort of the medical dental integration aspect of this. The Mayo Clinic is internationally known as an epicenter of good health care, but it also is a place that doesn't just want to try every new thing. And I think that the fact that you guys are with Olmsted County Public Health, I mean, that brings something. But could you just comment about, because since I'm old and I'm in the room, I'll just say that the fluoride varnish thing, that took years, and Amos Steiner, the pediatrician, is a very strong advocate to get those changes to go. And now you're asking to do yet another one with a caries arresting medication. And so if you just comment to the group about things that you've learned that we might find helpful as we try it.
I'm going to give a shout out to you because you were the one that told us about it. Yeah, right. Yeah. Well, it's helpful that the pediatrician we're working with came from California, and that was something that was happening there. So she was able to kind of move it along. But Mayo is a beast to get things going with. So we're trying to help pull some data for her because she's hamstringed right now. She has to pay for her own statistician to pull data.
So bring resources.
Yeah, bring resources. So they're doing chart audits right now to try and get that preliminary data. So once they have that, then they'll start piloting it. The other piece, our last task force meeting, we have an opioid task force that's going in the county right now. So we did bring the medical provider that's running that. He came to our task force meeting to speak on, because there were a lot of dental providers that were telling patients to stop taking their Suboxone because of what it was doing to the teeth. So we had him come in to say, please don't do that. So just trying to cross-share some information. So those types of things, just anywhere where we can bring that connection in. But yeah, the big piece will be trying to get that going with Mayo, which is probably going to take a while. Like you said, the fluoride took a while, so this will too. But with her history in California, I think she's going to be able to hopefully kind of push it through quicker than what the fluoride happened.